Hey everyone, we've got another fabulous case study for you. This patient has hip pain. Can you work out the diagnosis? Can you work out what's going on? We're going to guide you through everything in this video about this case, including the assessment and the diagnosis. So if you're ready to learn and put yourself to the test, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio. Let's take a look at this case study, starting with the subjective history. So today we have a 40-year-old woman presenting to our clinic with right-sided anterior groin pain. They feel that their symptoms started about 3 weeks ago, which they first noticed towards the end of a long run. And indeed they are doing long runs at the moment because they're training for a marathon, and they started training for their marathon approximately 3 months ago. So they've seen a private physiotherapist who has assessed the patient and has suggested that they have a hip flexor tightness, which is causing the symptoms in their hip. So what does the patient present with? Well, they have a dull, aching pain around the anterior hip and the anterior thigh when they're walking, but it's worse when they're running. And they've specifically noticed that as they run further, the pain tends to get worse. So if they're doing a longer run, the pain gets worse as they continue running, or if they do more running during the week than the previous week, the pain will also get worse. She feels that her symptoms have generally been getting worse over the course of the last 3 weeks, to the extent that she has now been experiencing discomfort and pain at night, which she feels is waking her up regularly during the night. And as for past medical history, this patient is an ex-smoker. She has a relatively low BMI considering her height, and she is a patient who has gone through the menopause slightly earlier than you may imagine in other women. So next, let's look at the objective examination. First of all, we do our gait assessment. We can see that this patient walks with a painful or antalgic gait, and in particular, they don't like spending time on their right leg during stance phase. It's clear that they don't like loading the right leg as much, and they're clearly limping on their right leg as a result, trying to get onto their left leg as quickly as they can. We have a look at the lumbar spine to clear this area, and we find that the patient has no pain at all on lumbar spine range of movement testing, full active range of movement of the lumbar spine with no pain at all. However, when it comes to their right hip, it is evident that there are restrictions. First of all, we can see that they have reduced hip flexion to only 100 degrees, and they clearly have reduced internal rotation to only 10 degrees. Both of these movements are painful. And it's evident that they are painful on both active range of movement and passive range of movement. And in fact, we saw that the restrictions we see for active are the same for passive as well. We then look at strength testing for the patient, and it seems globally a little bit weaker around the hip as a whole, where we look at all the different movements and we can see that it brings up a 4 out of 5 level of strength on the Oxford scale. However, because of the pain that the patient's having, we feel that this is the main restriction to them being able to do a 5 out of 5 rather than a true muscle weakness. So therefore, we go on to do some additional special tests, starting with a single leg stand on one leg, which on the right side is a little bit painful, but then when we ask the patient to hop on their right leg, it's significantly painful around the anterior hip and groin. And then we also do a Physio test, flexion, adduction, internal rotation all combined, and we find that this is also positive for the patient. So, with these thoughts in mind, this is your opportunity to think about what you think is going on with this patient. So write down your thoughts and join us again to find out the answer. Okay, everyone, time's up. Let's take a look at the answer to this patient's case study. Unfortunately, we were concerned that this patient had a relatively serious issue going on, in which that we suspected that this patient had a neck of femur stress fracture. This is an incredibly significant injury for runners, and therefore it's something that has to be investigated quickly. But the first thing to mention is not about the neck of femur stress fracture, but actually about the previous thought from the private physio that this patient may have had hip flexor tightness. What we actually find in clinical practice is that hip flexor issues are really heavily, overly diagnosed. And therefore, what we should be doing is thinking about a hip flexor problem as a diagnosis of exclusion, looking at other conditions first. Why is this? Well, when you think about runners, how much do they actually use their hip flexors when they run? When we're running, we actually use more of our extensor muscles to push ourselves from one step to the other, such as our gastrocnemius muscles, maybe our quadriceps muscles, and our hip extensors, our gluteal muscles, to actually propel us forwards. We don't drive our legs significantly forwards. And when you look at people who are running, you'll find that actually they don't move that much into hip flexion when they're running. Instead, it's more of the extensor muscles that are doing the work. Therefore, this is just one reason why hip flexor issues are heavily overdiagnosed in these patients, and we should be looking at other conditions that may cause this anterior hip and groin pain and thigh pain first, rather than a hip flexor problem. So therefore, we might be thinking about a neck of femur stress fracture like this patient has, femoroacetabular impingement, or even something like osteoarthritis in its early stages, rather than diving straight into a hip flexor problem. That is one key learning that we will take from this patient. Okay, so we've moved the hip flexor issues to the back of our thinking. What has brought the neck of femur stress fracture to the front of our thinking? Well, actually, it's a lot of the clues in the subjective history that has pointed us in this direction. And this is one condition where it's really important to be aware of the key subjective signs surrounding the diagnosis. So, the first most pertinent thing is this increase in activity, which is a really common story for bone stress injuries like a neck of femur stress fracture. The thought process is that when patients have been used to a low level of activity and then suddenly have increased their activity levels, particularly with impact or loading exercises like running, you're suddenly putting a lot more stress through the bone than it was previously coping with. So for this particular lady, she hasn't been doing much running, and then suddenly 3 months ago, she started doing this longer distance running because she's training for her marathon. The increase in impact and increasing load in that short period of time will put pressure on the bone tissue, especially when it's not used to it. So therefore, the fact that her pain in her hip and anterior thigh started and was getting worse as her running was progressing is a clear sign that it could be a bone stress injury that is causing her symptoms. Secondly, the fact that she's been experiencing night pain. Night pain makes us think of more significant pathologies like something like cancer, avascular necrosis, or a potential fracture, and therefore we should always be alert to patients who have night pain. But then it's probably this final thought that has been perhaps the kicker in thinking that we need to look further to think that this patient has a stress fracture, and that is her bone health risk factors. We noticed in her past medical history that she's an ex-smoker, which will have an effect on the health of bone tissue. The fact that she has a low BMI, this suggests that there may be reduced nutrition within her body over a long period of time and therefore less nutrition to the bones, which also may reduce the health of the bones in general. And the fact that she is a female who has gone through the early menopause. We know that as ladies go through the menopausal change, hormonal changes take place in their body, and therefore the reduced hormones that support bone health means that the bones are more likely to be vulnerable to injury. So we have this misbalance with regards to this patient. We have lots of increased activity and we have significantly increased risk factors towards a bone stress injury, which is the key reasons why the initial thinking would be a neck of femur stress fracture. It was therefore that the objective assessment in terms of the reduced range of movement, the gait disturbance, but most importantly, the pain with the single leg hop test that made me think, right, I think this is likely to be a bone stress injury. I need to proceed as if it is before I do anything else. And therefore, how would this patient have been managed? They would have been referred immediately for investigations, most likely in the form of an MRI scan in order to diagnose the neck of femur stress fracture or indeed rule it out. Even ruling it out allows us to proceed with physiotherapy as normal. But if you think this might be going on, diagnosis is key. And so get your patients referred on if you suspect a bone stress injury. So everyone, I really hope you enjoyed this video. If you have, please support us by smashing that like button. It's the #1 thing you can do to help our channel. And if you want more resources for physiotherapists, do check out our Instagram account at Clinical Physio. Give us a follow there for some brilliant resources for physiotherapists. Now, if case studies is the way that you like to learn, make sure you check out our membership channel, member.clinicalphysio.com. As a part of membership, you'll get access to the Case Study Club. The Case Study Club is a brilliant resource where we have different expert clinicians come in to describe patient cases and to describe the key clinical reasoning as to how they came up with their diagnosis for that particular patient. So if you like case studies, check out membership, a great way to learn for your clinical practice. My name's Khalid. Thank you so much for watching. See you soon here on Clinical Physio.